Good evening, everyone, and welcome to our Practice Nurse Orientation webinar. My name is Michaela Fennig. I'm an RN who has worked in general practice, so I have a good understanding of your role as practice nurses and also the importance that you have in the practice setting. Tonight I have Jan and Fleur from the practice support team helping in the background with questions, and Kira Wright from our immunisation team who will be presenting on immunisation. I would also like to welcome our other guest speakers for tonight, Karen Booth from APNA and Nikki Beckett from Head to Health. So I'd just like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I'd also extend that respect to any Aboriginal colleagues who may be joining us tonight. So I'd just like to introduce our first speaker for the night, Nikki Beckett, who will be presenting on Head to Health. So Nikki Beckett trained as a mental health nurse in the UK and has worked in both the UK and Sydney for the last 25 years. She has worked in a variety of settings, including older adult, community, adult inpatient, low secure forensics in the UK with males and high secure forensics in Sydney with females. She has also undertaken numerous clinical and managerial roles, including clinical nurse consultant and clinical team manager. Nikki is currently the clinical specialist for the Head to Health program across 3 sites in Bankstown, Liverpool and the Canterbury area of Sydney. Thanks, Nikki. I'll hand over to you.
Thank you, Michaela. Good evening, everybody, and thank you for inviting me along this evening to share with you this exciting new programme that the Central Eastern Sydney Primary Health Network is funding. I'm very fortunate to be part of 3 of the Head to Health pop-up hubs. We have 2 in the Southwest Sydney area, that's Bankstown and Liverpool, and we have 1 in the Central Eastern Sydney area in Canterbury, and we're based in Lakemba. So the Head to Health pop-up hubs came about as a result of COVID and the government's response to obviously making sure that people's mental health was serviced as a result of COVID, and finding obviously that people were having higher incidence of mental health distress due to the COVID and the implications that that had on obviously different areas of their life, whether it be employment or being socially isolated at home, whether it had an impact on their finances. So that's why we were set up. We are a free program. I know in the private sector there's a real shortage of appointments with psychologists, even for people that have the luxury of being able to pay privately at the moment. But for people who access Head to Health, we're very fortunate that we have access to free services, and part of that is psychology. In each site, in each hub, we have multidisciplinary teams which are made up of different disciplines. So we have, as I've said, psychology, we have social workers, we have counsellors, we have mental health workers, we have youth workers, peer workers, mental health workers who bring a drug and alcohol lens to people's situation, and people can access in some situations 2 of those members of the team at any one time, given their situation. And as I've said, it's free. We have a couple of referral pathways. So at the moment, we do have a triage number, which is across the whole of the state. And that's the number that you can see upon the screen, the 1-800 number. And we also have the option of people being able to call us themselves or to calling to the centre in person, which is the idea of the pop-up hub. So we're accessible and people can just call in and get support straight away in a timely fashion. So the referrals, as I've said, are easy to do, and hopefully has broken down some barriers in terms of people accessing support for their mental health care and their mental health needs. We are a short to medium term service, so we work for people from about, the average is 3 months, but no longer than 6 months. And the idea is that as we get to know people, we can signpost them and facilitate referrals to other services if they need longer term care. And I think I've covered everything. Oh yeah, the telehealth aspect. We again like to give people options and choices, and as a result of COVID, we've all had to rethink the way that we work. And I know for myself, being a mental health nurse and working clinically, the focus was very much on face-to-face appointments, and obviously we couldn't do that in COVID. So now we're offering people the choice. So the program is more telehealth based. However, if people do want to come in, again, we do have the pop-up sites and the office space where people can come in and do face-to-face appointments, or if they prefer, we can offer telehealth. So that can be a phone call or it can be a Zoom call, whatever the person prefers. And last point, sorry, we have so much to tell you, and I'm conscious I'm taking up your time, and I've got 5 minutes. We are for birth to death, basically. So our youngest client is about 6 years old, I think, the youngest referral, and our eldest client is 86. So we're not exclusively for adults, because a lot of services are either for children or for adults, but we're across the board from birth to death. So it's important to mention that as well. And the last point at the bottom is about the open hours, which I'm sure you can see there. So no public holidays, and Monday to Friday, 8:30 till 5. So hopefully I've covered everything. If you've got any questions, obviously I'm more than happy to respond. I believe you can write them in the chat, and then I can contact people outside of this meeting, because I know you've got a lot to get through. And if I've forgotten anything, I apologise, but I think those are the main points.
That's terrific. Thank you so much, Nikki. That was really informative. Thank you so much.
No
and
worries.
Just a reminder that if anyone's got any questions for Nikki, please pop them in the Q&A box and I will send them through to Nikki for a response at the end of the webinar. So I'd like to move on now to our next presenter, who is Karen. Karen Booth is the President of Australian Primary Healthcare Nurse Association. Karen has worked as an RN and manager in general practice since 1998. Her areas of expertise include preventative health, immunisation, infection control, diabetes, chronic disease care and coordination, data management, and accreditation. Karen has set up systems in general practices, including nurse-led clinics, supporting a team approach to care. Karen also has a keen interest in health policy, workforce development, and advocating for the role of the nurse in primary health care. Karen has over a decade's experience advising on national health reform and health workforce, and holds a number of ministerial appointments. Karen is a member of APNA, AAPM, Australian College of Infection Prevention and Control, and is a graduate of Australian Institute of Company Directors. Thank you, Karen. I'll hand over to you.
Pleasure. Thanks, Michaela. Michaela and I worked at the same practice, but not at the same time, just one after the other. So we've got lots of connections there. Now I shall share my screen, and looking at the poll that came through earlier, there's a lot of new nurses to general practice and to the primary healthcare space. So some of this is targeted generally at primary healthcare nurses, and some of it will be specific for general practice. But the crossover skills in most areas of primary healthcare, are very high. So I'll just go and share my screen, I think. There we go. I did it. More tech than I thought I could do. Okay. So the overview for this session, the objectives for tonight will be to have a look at the role of the primary healthcare nurse in general practice, look at the type of work that you might do around chronic disease and population health, looking at meeting complex needs and why in particular care planning is important, and at the end we'll talk about where you get support when you get stuck on those things, you're not quite sure, type of forms, type of activities, type of Medicare access, where you might get help to help you in your day-to-day role. So in Australia, they're just at the moment doing a head count of nurses. So the 2020 registration paper said there are 366,000 nurses and midwives in Australia. That's by head count. When you cut them down to full-time equivalents, they're significantly less. So that would bring that down probably closer to about 250,000 full-time equivalents. Of those nurses, about 20%, so nearly 90,000, I think, work in primary healthcare. In general practice, when I first started work in general practice, I had no idea there was a nurse across the road, and there was a nurse across the road for years. And it wasn't until she came in as a patient, and she was a patient of our practice, and the GP said, "Oh, have you met Sylvia? She works across the road." I had no idea for years. So it's being able to connect with other nurses through, say, the primary health network or through APNA has been really, really supportive and certainly life-changing for me at the time. So primary healthcare nursing, and in particular general practice, is one of the fastest growing areas of nursing. When I first went into general practice, they were talking about 3,000 nurses across the nation, and now we're at about 15,000 and growing. And the demand for nurses is very high. A lot of the government programs that are written, a lot of the health initiatives, have in mind that nurses will be the driving force for a lot of those activities, and in particular for population health. So fastest growing area of nursing, but also it's very complex care. And I think that's one of the things about primary health care that is, I think, somewhat underestimated. We've all trained as general nurses. So whether you're an enrolled nurse, an RN or a nurse practitioner, all of our basis is at a general nurse. And it's a very complex skill set. And the talents that you bring into general practice, whether you're a new nurse or whether you're coming from other areas, are highly important and will be capitalised on. Nurses actually add to the sustainability and the cost effectiveness of the workforce. So practices understand, and doctors are understanding now, that nurses are able to take on a lot of the tasks that they thought that only they could do. And doctors in hospitals are so used to working with nurses who, the nurse runs the ward, the nurse runs the show, the nurse calls the doctor when she's worried about the patient or he's worried about the patient. And in general practice in particular for older doctors, some of them haven't worked with a nurse for a while, and now they're catching on. Actually, we can give our patients much better access to care if we can add a nurse who can take over some of those things that are really not necessarily total doctor care. Agents of change, as I said, the government has a lot of programs that are coming through. You'll see information coming from the primary health networks about different types of programs, and they know that nurses will actually drive that, almost like project managers. You'll do the recalls, the immunisations, if there's an update on diabetes that needs to be rolled out through practices, often it's the nurse that pushes that. The College of GPs knows that too, and that's well documented in their, they have called them the Red Book, the Green Book and the SNAP guidelines. But they know there's activities in there that nurses will do to drive care and change in the practice. So complex care, they need nurses. It's too difficult for a single health professional nowadays to manage complex care. So to have a team member who is, a scientifically based health professional working with you to share that workload actually helps to relieve the pressure on the practice, But again, as I said, it actually helps to increase patient access to care. And the other thing is the health budget. So I think in the US, their health budget is kind of roughly about 20% of GDP. And in Australia, it's 10% of GDP. That's a very high proportion of costs in healthcare. And so we need to be smart about how we spend our health dollars. So to be able to use team care to redistribute workloads and to have that properly funded, that's another soapbox moment for me at some point. But to have that properly funded makes a huge difference than just to have, single visits to the doctor and then have to come back and see the doctor again and again. They can come in, see the doctor and say, okay, we've got 5 visits with the nurse, and during this time we're going to do some health coaching and we're going to do some, some wound care or some lifestyle management. So really to share that load and to make it much more sustainable picture is really important. And of course, having a nurse there encourages a forward focus for primary care, because the nurses are very heavily involved in planning the next steps for practices, next step for population health, the next steps for chronic disease management. So what's the problem? So this is my mother's 80th birthday cake, God bless her. And looking at it, 75% of all Australians suffer from at least one chronic condition. Illness is probably a strong word there. It's more a condition, whether it be pain, some mobility issue, some nagging issue. But when the Institute of Health and Welfare conducted this survey, 75% of people said, I have a health issue. 50% of people over 65 report having 5 or more long-term health conditions. And we've all seen a diabetic patient who has osteoarthritis, who has high cholesterol, who has high blood pressure, and so on. So we see them as a single person with a cluster of things, but they're, different, multiple health conditions. 1 in 5 people aged 16 to 85 and 1 in 4 aged 16 to 24 will have been affected by a mental health disorder in the last 12 months. Those statistics might have gone up a bit more from when this survey was done during COVID. And having Nikki on at the beginning actually is a very good sort of segue to be able to highlight this fact that people are stressed and they're coming to the GP. And anxiety is a very common presentation in general practice. Other things are changing. Type 1 diabetes that has increased by about 30% over the past decade. While the numbers are still not huge, it's increasing significantly, which of course is adding costs to individuals and their healthcare, as well as to the national system. Patients with dementia, there's probably half a million patients with dementia now, and expected to rise over the next 20 years. 25% of children aged 15 to 17 and over 60% of adults are overweight, and they are significant health risks, modifiable health risks that we can at least, if we're screening and counselling, have something to help with, to influence. And of course, end-stage kidney disease rates are rising as well, which means dialysis rates are rising. Kidney disease, diabetes and heart disease are linked together, as is kidney disease. Very rising rates of type 2 diabetes. So we really need to, again, it's a modifiable risk for most people, and to jump in there and see if we can, what we can do to modify that, and nurses have a role in that. So 11 million have at least 1 of 10 chronic conditions, And the most common ones, as we said, were mental health issues, back pain. The older you get, the sorer your back gets, osteoarthritis, and once you're over 65, we've all got back pain. So they're very, very common presentations to the doctor. And chronic disease, so coming into the type of work that you're doing, chronic disease is classed as a condition that lasts for more than 6 months or is terminal. And we know that the diseases like heart disease, cancer, stroke, diabetes, arthritis are increasing, asthma increasing. And more with fantastic treatment techniques we have nowadays, cancer for some people is becoming a chronic health condition, so a chronic issue. And nurses will have a role in helping with care planning and support once those people have finished their acute treatment and they've been discharged from the services. So we're doing a lot more care planning for patients with cancer, making sure they've had their follow-up. A chronic disease is non-communicable. So it means it's not like COVID or influenza. It's something that's non-communicable. So it's all of those chronic illnesses. Some of them have modifiable risk factors, so things that we can change. Things you can't change are age and sex and your genetic heritage, but there are lots of lifestyle factors that we have a role in intervening. Usually involves some sort of functional impairment or disability and can affect people of all ages. So we sometimes see kids with arthritis and of course with diabetes and asthma, so we can intervene with them. We see older people very commonly with type 2 diabetes, and just because you have a health condition doesn't mean you don't have to be well. And it's our role to keep people operating at their kind of optimal level, and to make sure that they get the support they need, to help them with self-care, so looking at monitoring their health and monitoring their own conditions, and of course intervening nice and early. And the two ladies in the picture there is my mother in the corner and her baby sister on the left, and they're rolling their eyes and laughing. One of them has lymphoma that she's had for 10 years, and the other one hypertension and chronic heart disease. But they were well. They're happy and healthy and well as could be expected. So they have really good care to keep them in that condition.
So Karen, we've just had a question come through. What's the increase in type 2 diabetes in children?
I don't have the statistic off the top of my head, but it is increasing. And the Children's Hospital at Westmead, I've seen talks by them that say it's, insulin resistance is probably more common than full progression to type 2 diabetes, but they're seeing it in 12-year-olds. And it's really important that we health check kids. So having that conversation with parents who are very touchy often about children's weight, it's important that you have that conversation to talk to them about levels of activity and to talk to them about how far out of range their child might be for their weight and about the health implications. As I said, a lot of parents, it's a very touchy subject. And we used to do a 4-year-old health check, and that was a few years ago now. And the health minister at the time did as a budget cut out the 4-year-old check. And it was the last time before school where we could do, height and weight and talk to parents about lifestyle and behaviours before school. And now we, you can still do that, but it's not funded, and it's not certainly done to the extent that it was. And it's a possibility that, you know, it can go from preschool to adulthood without having to have a health check. And so you miss some of those touch points with parents unless you're opportunistic and you know, and raise it with the parent and with the child.
Great, thanks, Karen.
Sorry, I thought I had edited out the fade in here, but I was when I was doing sort of PowerPoint practice. So moving to a team-based model of care. So the old-fashioned work of, you know, the solo GP, it's not sustainable anymore. We really need to share the workload. Some jobs can be managed completely by other health professionals. A lot of the patients that come into the practice, they come to see the doctor, but often they can be managed by the nurse. Most wound care can be managed by the nurse, you know, and some of the lifestyle discussions between doctor visits can be managed by the nurse. Some patients self-refer to the physio or to the podiatrist to have small health conditions managed. But for the current, in the current gatekeeper role for general practice, the GP coordinates a multidisciplinary team. And it's very important that there is a gatekeeper role. Part of that is so that there is someone, whether it be the GP or certainly the practice team, keeping an eye on complex patients. And self-referral is good to a point until something goes wrong and you realise there's been multiple episodes of care that aren't tied together. That probably could have been better managed in a much better big picture view and in a team care view. And nurse-assisted delivery of care, as I said earlier, is the major growth area in general practice. I do a lot of workforce discussions. There are whole country towns where there's no doctor, and they run on nurse-led care and telephone consults and visiting doctors in between. So nurses are recognised as a very highly capable workforce. So multi-skilled and multitask, we all come from different areas of nursing, and whatever you've done before is a talent that you bring into general practice or into primary care, whatever area you're working in. We're doing lots of things and often lots of things at the same time. You have one patient in the corner of the treatment room behind the curtain waiting for the doctor to come to top up that treatment. Someone's come in, they've fallen over, they've hit their head, you manage them in another corner of the treatment room. Someone else is outside crying in pain, you're running out to treat them. 3 doctors are calling you because they all want your help. But, you know, nurses are very, very good at multitasking. Collaborative care, so collaboration with doctors, with our allied health professional colleagues, and of course the patients are part of the team. So it's very important. You can't, gone are the days where you just tell people what to do. The patients are part of that team, and you work with them to build a plan that will help manage them to meet their goals. And it is their goals, not ours. We might have some for them, but it's all about what they can manage and how we share that information to make sure that we're all on a really good path with them. Service provider, nurses are service providers. Most of us now work in private practices. So we're private businesses and we're offering a service to the patient. They pay for that service. And whether that be through Medicare, we all pay Medicare rebate. In our tax, we all pay a levy that covers the cost of medical care for us, or whether they pay privately, they're paying for a service, and we have to keep that in mind. And of course, as I said before, nurses are often the project coordinator. So whether that be for a health a health program activity, whether that be running a recall system in a practice, whether it be helping with staff training, and many of you will, if you haven't done it already, will be more likely to be heavily involved in things like practice accreditation. And a change agent, because we know that nurses can fix and change everything. So acute care, all those things that walk in the front door, coughs, colds, cut hair, fallen over, that's primary care is first line, we're frontline care. Chronic disease management, which involves long-term care, ongoing care, and health coaching. And if you haven't had the opportunity to do some form of health coaching, whether that be a course or for CPD, or even to do online education and YouTube for health coaching, it helps you to help patients shift their focus and move from where they are now to where they want to be. What are the goods? What are the bads? It's like a SWOT analysis, but for health. And getting patients to say, you know, what are the good things about smoking now? What are the things that you want from not smoking? How do you think you'll feel? And then talk to how you might get there. So it's a very, very good approach to use health coaching. Preventative healthcare, screening, education of patients, particularly education for self-care. Nurses have a really big role in that. And I have to declare an interest. I'm a director on the Australian Self-Care Alliance. And AFNA has also, in our pre-budget submission, put in to the government for funding to develop education programs for nurses to help teach patients self-care. So hopefully that lines up with the preventative health strategy, and hopefully we'll hear more about supporting patients and helping them to take control of their health. And of course, we're all involved in public health programs. Everyone at the moment is immunising their brains out, I think. And this has been one of the biggest public health programs in decades. So nurses and nurses in primary healthcare have been key to that. I was at a meeting, I think something like between 70 and 80% of all of the COVID vaccines have been given through general practices. So if your hands are tied and you've got a bit of RSI, you know why. And nurses working to their full scope of practice is really important. It's a very poorly understood term, I think, scope of practice. Some people think, oh, well, that's what the boss lets me do. That's my scope of practice. But you have a standard skill set when you graduate, and then you build on that skill set and you can extend your scope of practice. Education, training, nurses being able to work to their best skill set gives people better access to care. It's much more cost-efficient way for running a health system, because you have everybody working, you know, to their highest level. And it's holistic care. So we're actually looking at a better picture for the patient. Michaela, any questions so far?
Not at the moment, Karen, so we're good to keep going, but please pop your questions that you do have in the Q&A box down the bottom, and we can answer them throughout the webinar or at the end. Thanks, Karen.
Yeah. So this is one of the favourite things I do, I think any of us do in general practice in particular, or in child health, is to do baby checks and to do immunisations. And all of that is part of developmental care, but also it's public health. initiative as well. We're very fortunate in this country to have access to a wide variety of vaccines for children at no cost. And some people have to pay for the medical visit, whether you're private practice or bulk billing, but the vaccines are worth, often hundreds and hundreds of dollars at each visit, and they're supplied free as part of a national public health program under the National Immunisation Plan. And to some of you, we'll be heading down the path for nurse immunisers. I can highly recommend the course, and there are a number of courses around, so it's good to shop around. The quality is slightly different and the cost can vary significantly, but the PHN team have really good information about courses and which ones to access.
Karen, just one question on vaccination in general practice. So one of the questions that we do get asked from nurses are, if they are not a nurse immuniser, can they immunise and give a vaccination if a GP is not in the room at the same time?
If the GP's in the practice and they've got a standing medical order, then that should be fine. And often the patients might see the GP and then they'll come into the nurse to have the vaccines done, and the GP will move on to the next patient. And that's kind of standard practice. You don't have to be a nurse immuniser to give a vaccine. An enrolled nurse and a registered nurse can give a vaccine on a medical order. It's often good to check the vaccines, to say to the doctor, okay, these are the ones you want, show them the vials, and then take the mum and the child into a quiet space. But you don't have to be a registered immuniser to give a vaccine. The accredited immunisers can give vaccines without the doctor being in practice. Covered in their scope of practice, the biggest hitch for all of us, of course, is how you build that. And if we change to hopefully some sort of health reform package where we get bundled payments or direct payment to the practice, it would be much better than fee for service. In a busy general practice where there are lots of doctors around, that's an easy thing to do. It's when you have staff shortages that sort of thing becomes harder.
Karen, could you please explain what a medical order is? Because I get my tongue tied when I try and explain that. Please, that would help me as well.
Okay, so the National Immunisation Plan is great because there are set doses for age groups, and so that's where you will be. The doctor can give that order verbally. So you say, oh, can you please take, little Mikey here and give him his 12-month vaccines. And I always document, seen by Dr. Jones for this level of vaccines, and that is adequate. Or if the doctor puts in the notes to have 12-month vaccines. For accredited nurse immunisers running flu clinics, again, they're covered under the accreditation to do that without a medical order. But yeah, it is as long as they have, it's in a practice policy as well. So that's also a handy thing to have, that that the nurse can give the vaccines once it's authorised by the doctor. But again, I always document that the patient has been seen by Dr. Jones if he attended any health checks, and that to proceed with this particular age immunisations. He's very cute, this baby. He's probably about 15 now.
Thanks, Karen.
That's all right. So this young man here is flirting absolutely outrageously with my colleague Alice, who's saying she's got a teeth clench, going, don't leave me alone with him. Just mostly because he was such a funny, lovely man. And while he's laughing away, he has the most shocking back osteoarthritis and sciatica, terrible, terrible knee osteoarthritis. And he's here having his over 75 health check. And from this appointment, we were able to then bring him back for care planning, and we referred him for some exercise physiology visits I was fortunate to have an EP close by that specialised in aged older people. And we also got him an appointment to the neuro clinic at RPA, because I was at Leichhardt at the time, to actually get his spinal cord compression looked at. So it's a very worthwhile thing to do health assessments. People tell nurses a lot more often than that they don't want to worry the doctor with, or they're a bit shy, a bit embarrassed to tell the doctor, but they will share a lot of news, a lot of information with nurses. Very good to be able then to document that stuff, because it actually, is on a pathway to making their, often their health conditions are deteriorating without them fully understanding the significance of that. So from him, we got him back. He was became much more mobile, which was good. And the most important thing was pain control for him. So some proper pain management. And this sort of took, just one of my favourite patients too, she fell over at the bus stop and took some skin off her arms. So nurses, we're doing procedures all the time. And of course, the thing that goes hand in hand with procedures and dressings, infection control. So nurses often are they're usually the key leaders of infection control in their practices. They'll do the instrument sterilising, they'll do the staff training. Everyone, I'm sure, has honed up on their special COVID infection control skills, and the first person they come to is the nurse. So not just general practice, school nurses, community nurses, aged care have all had a big elevation in recognition of that infection control skills that they have. From this visit, again, this little lady was tottering, and we brought her back to do some care planning and to get her into a strengthening program, so that she, when you're older, often you sort of lean forward as you walk and she overbalanced. So our goal from care for her was to strengthen her, bring her a bit more upright, keep her mobile and at home. So nurses have an important role in primary healthcare, support for medical staff. So you're important backup, and they can share not just the workload, but patient stories and care guidelines. You support patients in the care that you give them, and you're using lots of clinical skills. So triage and assessment, really acute care skills. And of course, giving treatments, ongoing care and management of chronic diseases. And you plan and coordinate. And so nurses have a huge role in care planning, following up, seeing, have patients attended their appointments, what's the next step, and reviewing that care, bringing them back for reviewing that care. All really key roles in primary healthcare, and in particular in general practice.
Hey, Karen, we've just had a question come through about referral for a patient that may have chronic back pain. Do you suggest if there's a preferred referral pathway for a patient suffering chronic back pain?
So there are some good pathways. So Health Pathways will have something on there about referrals for chronic back pain. most physios can manage chronic back pain. So if the GP does, whether they want to do investigations, if they need, patient needs ultrasound or an X-ray, that's not absolutely necessary, but good physical examination, identifying where the pain is coming from, making sure it is a musculoskeletal issue, and then, you know, through a care plan for someone with a chronic condition, they can be referred, they'll get 5 visits, subsidised visits with a physio, and then the other goal will be to have a self-care plan at home. So getting the physio to help, or the exercise physiologist to help give the patient a plan to manage sort of ongoing exercise and strengthening at home. So it doesn't matter, it can come through care plan and then to a private physio, and there will be a gap for them to pay, but they get a $50 or $55 rebate against those visits for allied health. So I think that's really important. It's made a huge difference over the years from when I first started in general practice. And if you couldn't afford a private physio or private allied health, to go on hospital waiting lists to get into clinics was sometimes a couple of years. So to be able to have instant access and to a physio that you know, a physio that you talk to, that the patient can get to know really well is important. So the other thing for everyone coming into particularly small private business is that medical practices are small private businesses, and a lot of nurses coming from hospitals will never have had to, unless you're a manager, will never have had to manage a budget. And some practices run their treatment rooms with a budget, but you need being cost aware, I think, is important. If you bulk bill a patient, then probably, well, technically you're not allowed to charge them for supplies. There is a Medicare Reform that went to Parliament that was supposed to, well, we thought it was coming through, it's probably held over now, where there would be a plan to reimburse people for some practices for dressings for some people with chronic wounds. Very expensive. I don't think that the patients understand that if you get out a wafer or some of the wafers or the ulcer dressings that are only, you know, 10 by 10 centimetres cost $10 each. And if you're bulk billing a patient and you put on a $10 dressing plus the cost of the dressing packs plus the cost of the bandages, then that consult bulk billed is probably worth not much at all. And so GPs and practice managers in particular are very aware of the cost of dressings. Some practices will get patients to buy their dressings themselves if it's going to be ongoing, and some practices will refer them to a wound clinic. For immobile or less mobile patients, community nurses, you can arrange community nurse visits. Some community nurses, depending on the area health service, there's a fee for them to come to the house or a fee for them to cover dressings. And so, yeah, I suppose the bottom line here is to understand that that there's a cost involved to running the business and to managing supplies, and we just probably need to have some awareness of that. But the other thing you need to be aware of is your contribution to the bottom line. So nurses do a lot of that high level and high funded activities such as care plans and health assessments. And it's a good idea for you to know the type of things that you're involved in, the type of income that you generate for the practice, and that nurses aren't just, they're not cost to the practice, they're actually a benefit for the practice. They help the number of patients coming through the practice usually increases when there's a nurse, because the care is managed much more efficiently. And there are also incentive payments that come to practices as well. So depending on your swappies, the maximum that comes to a practice is about $125,000 a year at the moment. And it's broken down into segments of how many patients you see and how many hours the nurse works, into the quarterly payments that will come to the practice to help subsidise the activity of the nurse. So there's a back-end payment from the government to have you there, as well as what you contribute to billings. So it's really good to know that actually you are part of the bottom line for the practice. And needing to be up to date. So subscribing, if you can, to the newsletters that come from the PHN. APNA, Primary Healthcare Nurses, has a newsletter. And if you're not a member, you can sign up for the newsletter, they're free. And we send through everything COVID, any changes in legislation, any changes coming through from the Nurse and Midwives Board, lots of topical news, and latest trends. That this week APNA's newsletter is talking about monkeypox, which makes a nice change from months of COVID, and of course trends in influenza. So keep just on top of those, what's happening in my area, and that helps you to pre-plan. If you know that, say you're in the Sutherland Shire and there's a big flu outbreak, then that will help you plan. You'll know what's coming in the door, making sure that the front desk staff have got a good knowledge of, triage, infection control, keeping patients at bay until you can assess them. To know about Medicare items, because your activities are billed, and again, it comes back to knowing what it's worth. A lot of slippage in general practice, and the practice support team can tell you about that. People forget to add billings, and they often forget to add the nurse billings. And I know one practice who went back and counted all the nurse visits that weren't billed, and then billed them over from a 12-month period, and got back, I think it was about $30,000 or $40,000 in missed billings. And Medicare kind of paid. They understood that that's an issue. Knowing what your local community health programs are and resources. So whether it be a program run through the PHN that you can send patients to, the local council, a local NGO, what sort of health programs, resources or supports that are available. Big issues with privacy legislation that you need to be aware of, and that should be built into your practice policies, and they should have some guidelines in the practice for you. Standards for general practice. Anyone that sort of hears the word accreditation, they either roll their eyes or it strikes fear into their hearts. But the standards of general practice are, I think they're fantastic. And having started in a system where they're before the standards, and now working to standards, makes a huge difference for quality and safety and accountability. And of course, all of those other things, working within boundaries of registration. There are competency standards for enrolled nurses, RNs and nurse practitioners. I've got that written around the wrong way. And I have put links to a number of resources that you might find helpful, particularly the general practice competencies we'll come to. Knowing the limit of your clinical skills in particular areas, so that if someone asks you to do something you don't know what it is, it's okay to say no and then go and learn about it. And you can extend your skills through on-the-job training, through workshops, through professional development programs, and many nurses will go on and do tertiary level studies again, postgrad studies. But you can extend your skills. You're not you don't come out, that's it. You can grow like you would with any career possibility. Things for nurses who are really new, to make sure you've got a role description or a position description. So what is the expectation here for me? What do they want me to do? And of course, again, as you extend your skills, you can ask for that to be changed or updated. You should have a contract, and that's certainly all staff are meant to have a contract. Sets out the pay rate, sets out the award that you're under, the hours of the week. So just to make sure, and the conditions of your employment, full-time, part-time, casual, to have that there in black and white for you. Your practice should have an orientation program. So whether you're brand new nurse to general practice or you're making the jump from the tertiary sector into general practice or other primary care, there should be some sort of orientation around the business of the practice, how they like to run things, and so that you know how everything works. Professional indemnity insurance. I'll have 2 slides on this, so we won't dwell much on this, but you need to be aware of what type of insurance your practice has and how you are covered. Policy and procedure manuals, you should have access to those. Most days nowadays, people have that in a digital format. How to work the equipment, how the IT works, whether it's medical records or billing systems. Are you allowed to put billings in? I would say yes to the nurse billings, and the doctors need to put their own doctor billings in. And it's probably too convoluted to talk to that, but it covers you for insurance and claims purposes. Cold chain management. Nurses are the kind of key people in charge of cold chain management and making sure that the reception staff know how to manage the fridge as well, because they accept vaccine deliveries. Infection control, occupational safety, all of those other things are often referred back to the nurse because they think you're the expert. And if you're not now, you will be by the time you finish. And different types of info. How do I get to work? What do I do if I can't get to work? Skills update. We were doing CPR this day, the whole team doing CPR practice, but making sure that you have regular, you can update your current skills and to learn new skills. So any questions there, Michaela?
So Karen, we've just got one here. Could you just give a brief explanation of the expectation of an RN if the practice also employs an EN?
Sure, very common question. And enrolled nurses can work under direct or indirect supervision. An enrolled nurse can't work in a practice where there's no formal arrangement with a registered nurse. So that's part of their registration conditions. And the practice needs to have an RN who is contactable if that EN needs support. As far as skill set, I've worked with some amazing enrolled nurses and who have developed really good skills around care planning and patient support. But they also need to be aware, or RNs, it's okay if you're happy that the EN is competent in the activities that they're meant to perform, then they can be supervised indirectly. There's some information on the app and website that I'll dig up and send to you. And I think we did a podcast, Sue and the team from APNA did a podcast around EN supervision, and it certainly also came up. There's on the NCs, the National Centre for Immunisation Research, have a sheet on giving immunisations and who's who in the zoo for RNs and ENs giving immunisations. So tomorrow I have a dig and send those resources on.
Great. That would be terrific, Karen. We just have one other question here. What are some words of advice you would give new nurses to overcome challenges? So, for example, the workload or staffing shortages, etc., in the practice that they work in.
Very good question, and I'm sure just about every nurse is asking that at the moment. Look, I think you need to, if the workload is unreasonable, you probably need to say that to the manager and just say that if you're feeling stressed and you feel your workload is excessive, then, you know, that is a potential risk to the practice. It's a risk to the nurse for injury of some description, whether that be a mental health injury or for, you know, just you know, kind of risk from stress, and the practice needs to know that, and you need to have a workload that's manageable, and that's an occupational health and safety risk for the practice as well. You know, that if the nurse has to go off on sick leave because they're overburdened. I know there are a lot of nurses working very hard at the moment, and I'm a member of a couple of chat pages where the stress levels are very high. It's hard to recruit nurses. So I really think that practices really need to be taking care of the nurses that they have, and certainly managing workloads. You can ask for blocks in your appointment book. Just say, okay, I've got 3 care plans in a row. Can I have a block to make sure I can catch up? And they're all quite reasonable things to ask for. And if you're really not sure or you're wanting some more advice, APNA has a nurse support line, but also you have a great team at the PHN that might be able to advise you on strategies that you might use to have a chat to your employer.
Great. Thanks, Karen.
Probably not a straightforward answer, but it's probably at the moment, it's difficult times. And when you're new, I think that employers need to take into account the fact that this is a new role for many of you and that you need that additional support. Okay, Strive for 5. You probably all should know about Strive for 5 and the National Vaccine Storage Guidelines. Nurses, of course, we know, are the cold chain superheroes, managing millions and millions, hundreds of millions of dollars worth of vaccines over the last couple of years. The storage guide is there. The link to Strive for 5 is in the resource sheet at the end here, and there's a temperature chart. Some fridges have the digital temperature monitor, makes it very easy. Some of the newer fridges have back to base alarms. At the practice I worked in Hurstville, there was an app attached to the fridge, and if the fridge went out of range, the practice principal and the chief nurse got text to their phones that the fridge was out of range. It was an immediate call to practice. So there are all these clever new technology that makes managing the temperature much easier. You still have to record the temperature twice a day, and some people prefer to have the paper recording because it's easy to see. And I know that the PHN will have access to this particular document, but again, there'll be a link in the resources to that for you. Now, a bit about APNA. The things we do are looking at raising the profile of nurses, of primary healthcare nurses in a lot of sectors. So the biggest chunk of our membership are nurses from general practice, but we also have increasing number of nurses from aged care. We have prison health nurses, we have school nurses, sexual health nurses, community nurses. So a huge range of nurses from, you know, inner city practices to quite remote area nurses. And we lobby and advocate on their behalf. APNA has a career and education framework and a My Nursing Future website link from our main page. The education frameworks are for enrolled nurses and for registered nurses. And the idea of that is that everything you do, so whether you do CPD tonight or you do a short course, is that you help to build your profile and to build your portfolio of your skill set, so that, you know, you have evidence for your own professional development, but also for you know, future employment activities. You want a pay rise, you can say to the boss, well, here you go, I have done all of this education that puts me from the beginning sector, I'm now intermediate skill set. It helps you kind of demonstrate where you're at. We've got a transition to practice program that runs as a pilot program that we get funded from the government to do a set number a year. A number of employers, because it's a competition to get in, it's very competitive progress as part of the pilot program. But a number of employers are actually purchasing the transition to practice program. You don't have to be in a pilot program to do the program, and it comes with we look at mentoring, peer support, and online education and nurse support line. We have guidance on establishing nurse clinics. So if someone says to you, I want you to run a chronic disease clinic and call in all the type 2 diabetics, APNA has, and it's free on our website, a program for building nurse clinics, and, you know, things talk about budgeting and how you do a recall system. And the PHN also has a lot of really good resources, and they link up with APNA, which is really good. Chronic disease programs, and we're running a student nurse placement in primary care program. And last year during COVID, we managed to place 400 nurses in the middle of the nursing students during the lockdown in Melbourne. So we actually did really well. So the building blocks for the clinics just help you with planning the process and helping if you need to make a pitch to the practice. If you want to run a clinic, say you want to call in your COPD patients and think you'd like to run a COPD clinic, there are building blocks that are accessible. When you go on the website, you can hit those links and it takes you to the different building blocks of the plan. And these also align very closely with the with primary health reform activities that are happening nationally. A couple of publications I thought you would find interesting. So the nurse practice standards in general practice, that's hosted on the ANMF website, so on the union website. There's a link in the end. APNA has published a book which I would highly recommend, Foundations of General Practice. The book costs about $90, but it's yours, it's a hard copy, or put it on your practice manager to buy it for the practice. You know, lots of helpful tips in there for nurses. And we've just publishing Foundations of Aged Care. So that is in pre-order at the moment. And then hopefully by the end of the year, we will have the Foundations of School Nursing booklet reworked and out for publication as well. Oh, gone up. There we go. A couple of other things, books I thought you might well, not might, you actually probably handy to know, is the standards for general practice. So the accreditation standards, that's free, hosted on RACGP website, and the infection control standards are also free on the RACGP website. And I have to declare that's my favourite, because I helped with the editing of the last version, and it's just under review at the moment. So that is a really, really good book. So I'll just plough on to professional indemnity. And a lot of nurses say, so why do I need my own insurance? And I think we need to know that AHPRA changed the registration arrangements some time ago now, and all nurses have to have evidence of professional indemnity insurance. Whether you work in a hospital or whether you work in a private practice, you must have professional indemnity insurance. In big hospitals, it's easier. You know, they have a group policy that covers most nurses against being sued, and that will also, certainly to a point, cover legal costs. But in private practice, it's different, and it might change employer to employer. So you really need to know, ask the practice manager for a copy or the details of your professional indemnity and cover with practice. All practices will have some sort of professional indemnity cover for the practice. The doctors have to have their own personal ones, but it's still, the practice has to cover them to a point, and cover all of the staff as well to a point. The time that it gets a bit iffy is if the employer says, I didn't authorise that. The other thing, if you're looking at an insurance product, whether you're in a big system or small or personal, you need to have a run-off cover. And so if you injure someone accidentally tomorrow, you need to have run-off cover that will last you for at least 7 years, because they have 7 years to come back and sue you. So you need to make sure that you have run-off cover in that policy. The type of work I do, so I still go back and do some work in general practice. I've been doing immunisation clinics on and off. I do sort of advocacy work. I do some teaching, and I also do some consultancy work. And I have a professional indemnity policy through APNA that covers all of that. So you need to look at if you're doing subcontracting work. So if you're a subcontractor being paid through an ABN in your practice, and there are some employment arrangements like that, you definitely need to have your own insurance. And if you do work outside, if you do volunteer work, you know, at soccer, you're a first aider, you should have a policy that covers you for that type of activity. And as I said, the biggest risk is if your employer says, I didn't authorise that, and your employer is the person that owns the policy, you'll be covered to a certain point, but maybe not. And it's certainly worth looking into. Bit of a hard sell. I don't want to sound judge, but like my policy with APNA costs me less than $150 a year, and it covers me for 3 episodes up to $10 million each in a year. It's fully tax deductible. Some employers are coming to us buying policies for their nurses as well, so it might be worth having a chat with your employer. That's really, really cheap cover when it costs doctors a couple of grand for GPs to, depending on whether they're procedural or not. So it's I think the safety for me, I think is that's why I have it. So who can help me? Central Eastern Sydney PHN can help you. They are an amazing team, and I have, I don't know, been associated with them for nearly 20 years in different iterations. And, you know, the connectedness, and when we all get back to see each other, to be able to go to those events, to be able to have, you know, to be able to contact the support team that's local to you and know your issues is really helpful. They have great resources and great CPD sessions. They have great CPD on Backview with webinars as well. And APNA, we're there. We have a nurse support line. And if you're not a member, we still talk to you. Some organisations won't, but we'll talk to you at least once or twice and see if we can send you in the right direction for help. Advocate, I don't know, arguing with government people all the time about why they need to lift the game on nurses, and I look forward to catching up with Mark Butler again once he's back in his ministerial role. APNA has we've got a conference roadshow doing rounds. So the first one kicks off in Melbourne this week. We're coming to Sydney in December, and that'll be 2 days of education and networking and a 21st birthday party. And I get to attend quite a few, so I'll be to a few 21st by the time December comes around. But very good program, and that link to that's on the APNA webpage. And then in here are the links for all of the resources I've talked about tonight, the clinic setup, the foundations workbook, how you can get that information from the nursing board and APNA on professional indemnity insurance, and the links to the College of GP Standards. And I would also say make MBS Online your friend, so that you know different item numbers and you know what your work is contributing to, and how much you're contributing to the bottom line of the practice. Done.
Great. Thanks so much, Karen. That was fantastic. Thank you so much. And if anyone else has any questions for Karen, please pop them in the Q&A box, and we will endeavour to answer them all and send them through at the end of the webinar tonight. So I'd just like to introduce you now to our next speaker. So that is Kira. Kira is the immunisation team leader here at CESPHN, and she's been working here for over 5 years. Thanks, Kira. I'll hand over to you.
Thank you, Michaela. Hi, everybody. Thank you, Karen. That was an amazing introduction, and great to show everybody all those skills. So I just wanted to give you a bit of a overview of what we do in the immunisation team at the PHN. Obviously, doing immunisations, we work a lot with nurses. Just to let you know, I'm not clinically trained, but in the immunisation team, we like to call ourselves the resource queens. We know where to find everything you need related to immunisation world. So we're always a phone call or an email away. Tonight, I'm going to quickly just go over important websites and resources that you should be bookmarking, how to order vaccines, a bit of cold chain management and what to do in a breach, getting access to air via PROTA, the NIP, New South Wales additional funded vaccines and catch-up schedules, vaccine safety and hesitancy, and how to transmit those vaccinations to air via your PMS. And then Karen already mentioned it, but a bit on the scope of practice. So these are the important websites that you need to know about and should be bookmarked on your computers. Obviously, first is the Immunisation Handbook, also available as an app, so you should definitely be downloading that. The New South Wales Health Immunisation Program, that is your one-stop shop for the immunisation world that we live in here in CESPHN. NCIS has great resources as well. For COVID vaccines, the Department of Health website is, where we get everything from. And then, of course, our CESPHN immunisation page is your one-stop shop for everything immunisation. Firstly, the Immunisation Toolkit. This is a great resource, contains everything you need to know for all your immunisations. Like, this is the second most important thing in addition to the Australian Immunisation Handbook. And on that, it includes how to order NIP vaccines. That's via that website. Routine vaccines you can order once per month, and sometimes you can, if you need an emergency order, you can order twice per month. And for flu vaccines, aim for no more than 2 orders per month. Cold chain management. So Strive for 5 is your cold chain Bible. It has everything you need to know relating to cold chain, and I know it's a long one, but if you can flick through it, it's going to have everything you need to know about keeping your vaccines safe. There's also the compulsory course that has to be done by one person in the practice at least. But if you have a breach, the public health units require everyone on site to do the course. So it's a great idea to just do it to begin with. I will show you links to all these on our website as well at the end. Stock rotation, expiry, and disposal. So obviously, whenever you get your new stock come in, you rotate the older stock to the front, put the new stock at the back, check expiries every, month or so, and then disposal of expired vaccines is, you've got to let the vaccine centre know online, and then you would just dispose of the vaccines in your clinical waste or drop at the pharmacy, and then just, put any needles in the sharps bin and recycle the boxes. A few fridge stocking tips. So obviously labelled baskets, get those baskets from the dollar stores, label them, colour code them, and make sure that you're allowing airflow around the products on the shelves. So don't put anything on the sides, don't put anything at the back. And definitely keep your vaccines in the packaging because, a lot of them are can be exposed to light and then they won't be efficient anymore. As outlined in Strive for 5, you need to do twice daily monitoring. So that's again what Karen mentioned earlier. You can also use our twice daily temperature chart here, or the landscape chart where you can just plot them on a graph. Whatever works for your practice is fine. And then you definitely need a data logger, that's compulsory, and it needs to be logging every 5 minutes, and then you need to be downloading that weekly. The best data loggers on the market at the moment are the ones that you set and forget. So you literally just put them in the fridge, you have something connected to your internet usually, and then you just get notifications and you can log on online once a week to download the log. And then, whenever it goes out of range, whoever's in charge can get a text or an email, and it's pretty fail-proof. And then as well, there's the annual self-audit that you must do every year, and that's in the Strive for 5. And then lastly, do you know what you're going to do if there is a power failure or a fridge failure? So do you know your backup plan? If you don't, create one. There's great templates in the Strive for 5, and UPS is another great option. So everyone should now know about AIR due to, COVID vaccinations, but as nurses, we need access to AIR. So you get access to AIR online site via Proda. So you need to create a Proda account. And then once you have that Proda account, a GP in your practice needs to delegate you access. So you can do things that a GP does, like enter vaccinations, look up patients, etc. Once you've got delegation access, you can also request AIR reports. So this is how you would identify patients in your practice that are overdue for vaccinations. So things such as the 10A report, which is due overdue report by immunisation practice. So for that, you enter in a PIP number, and it gives you a list of everyone that's due and overdue for vaccines that has had an MBS service item at your practice. So then you would just filter that to the overdue ones and get a shorter list of those that you can call in. The 11B is due overdue by vaccination provider. So a single provider can request that report, and they just get their own sheet of their patients. And then the newest one on the air is the Air 42A, which is the COVID-19 vaccination status report. So you can use this report to target your unvaccinated people or your partially vaccinated people, those that are overdue for boosters, and you could also target certain age groups. So say the over 65s, or if you want to focus on your childhood, the 5 to 11s are good places to start. I just want to mention as well, with the due overdue reports, you can use those to see who's due and overdue for things like pneumococcal and Zostavax in your older populations, because the Zoster on the schedule was extended till 2023. So yeah, in the lead up to that, you can identify those patients that are due for Zoster and give it to them free before they miss out. Just on the NIP, obviously make sure you've got the latest version of the New South Wales immunisation schedule. I think it's October 2021. I had it on the slide earlier. So that includes all the NIP vaccines, and then it also includes some like the flu vaccines that are available. And then it also includes the additional vaccines that are required for Aboriginal and Torres Strait Islander people. So make sure you know those, make sure you offer them, especially the meningococcal B in children. That's all funded under NIP for Aboriginal and Torres Strait Islander people. There's also the additional funded vaccines by New South Wales. So that's this picture that I have here. There's a link on our website to that. So just know those for the populations that can receive them. And then there's the catch-up vaccines for people aged 10 to 19, and then those aged 20 years and over. And then as well, just make sure you know your recommended vaccines in pregnancy, so influenza and pertussis, and when to give them. Vaccine safety. So you need to know what an AFI is. So there is, some things you could have a little adverse reaction, but it doesn't qualify to be reported. So know the difference and then know where to report. The anaphylaxis kit, make sure you have one of these in every treatment room. So that's, again, that picture on the screen, which is on the Australian Immunisation Handbook webpage. NSWIS is a great place to call when you have questions that you may have about vaccine safety, or if you've given only half a vaccine and you're not sure. And they also have been super helpful with COVID vaccines over the last 12 months. And then NCIS and AusVac Safety, they do safety reporting and represent the data. So again, I'll show you where all these things lie on our website. And then vaccine hesitancy is a tricky topic for anyone, obviously, but Sky has some great resources on how to help assist in directing conversation with those hesitant parents or adults. So they're great resources as well. And there's also an online training module that you can do. So practice management software, ensure you're using the latest version of your software, because that's the only way to ensure that you're doing everything you can to stay up to date with the latest schedules, and also making sure that things are transmitting to the air live. So make sure you're entering vaccinations correctly. So make sure you're selecting the correct vaccine, who it's given by, the date, the route, the site, the sequence are all correct, the batch number and the expiry. You need to ensure that all those things are there for it to be successfully transmitted to air. Transmitting vaccine encounters to air via practice management software, as long as you've got the latest version of the main software providers, it does do it instantly these days, but I would just check with your vaccine provider if you're not sure. And then also utilising the recall and reminders. So make sure when you are entering your vaccine, you are adding that recall reminder then and there, so you don't have to think about it later. Vaccine uploads for non-Medicare patients. So medical director, you will need to do this manually. So you need to log into AIR and manually add those vaccines, but BP will transmit them, so you don't need to worry about it if you use BP. And then entering overseas vaccinations and immunization histories. It depends on your PMS as to whether entering it on your PMS and then transmitting is enough. So again, check with your provider, but the safest way, I think, is to just enter it in your PMS to know that you've got the full scope for your patient's medical history, and then as well, you know, maybe in a day or so, you can check if it's gone onto the air, and if it hasn't, then you can enter it manually. So Karen already mentioned scope of practice, but I just wanted to highlight this resource that is comprehensive about what type of nurses can do and can't do what. And then as well, the authorised nurse immuniser courses that are available. So that is our contact details. And I will just quickly show you the website. I know we're over time, but I just wanted to go through. So from our PHN main page, you will go to general practice, just hover down to immunisation homepage. And where are we going to start? So definitely apply to receive the Sydney Health Weekly. We do a weekly immunisation update on that. And we also have all our past updates here. Our support contacts is where you would go to find the public health unit numbers and emails, our numbers and our email, the AIR, PRODA, NSWIS, etc. Important websites. So that's where I mentioned all those websites earlier. This is the links to all of them. So I would bookmark all that would help you in finding information, and have a, you know, look around and see where that information is. In terms of the NIP, you can go down to resources. And this is the toolkit that I talked about. So this is the, you know, after the Australian Immunisation Handbook, this is the second most important thing to read. And then there is here the list of the schedule, funded vaccines, catch-up vaccines, additional vaccines, non-Indigenous and Indigenous recommended vaccines. So there are additional recommended vaccines that aren't funded. So that obviously is meningococcal B for non-Aboriginal people. They're not funded under the NIP, but definitely recommended. Also, a second shot of varicella is recommended, but not funded. So there are things on there that to think about and offer to your patients. Our cold chain management page is full of everything you need. So just have a look. I won't go through it all due to time. We also have our AIR webpage. So it's got everything on how to register for PRODA, and then how to link that, and then how to delegate your access. And then once you have access, how to log on, how to access patient records, how to download reports, etc. And lastly, I'll just show you our nurses page. So we have a scholarship for RACF nurses at the moment, where I think we might be going to the wait list, but there might still be some spots. So just apply. And there's also a waitlist for general practice nurses. So we don't have any scholarships happening right now, but if the opportunity becomes available, if you put your name on this list, you'll be the first one we'll let know about. But in the interim, we do have a 20% discount offer with the benchmark authorised nurse immuniser course. But just to let you know, HESA has a list of the all of the institutes that offer the authorised nurse immuniser program, and like only 2 years ago there was 2 listed here, and now there's this many. So it's great to see the improvements that we're making in this world. Let me just go back. Also, our COVID page has, over the last year has been our most updated page. So it's very comprehensive and has everything you need. But due to time, I think I will leave it there. But lastly, please just contact us, immunisation@cesphn.com.au, if you have any questions. We're always there to answer anything you need. So yeah, thank you.
Great. Thanks so much, Kira. I am aware just of the time. We have gone over a little bit, but we do have a question, Kira, if that's okay. So someone is asking that, can we register with AIR without the GP delegation if they are an AIN?
So you can get PROTA access, but I don't think you'll be able to get that AIR access until you've got the delegation, because the delegation provides a provider number which is associated with the GP. Unfortunately, at the moment, AINs don't have provider numbers, which would be amazing if they did. But for now, yeah, you need that GP to give you the access because of that provider number that correlates to that GP.
Great. Thanks so much. If there's any other further questions, please pop them into the Q&A and we'll forward them on to Kira for answering at the end. Thanks, Kira. That was really great.
Bye, everyone.
Thanks. So to also help support your role in general practice, the PHN has developed a practice nurse resource guide. And some of the information that you will find in this guide is how does CESPHN support nurses, the nurse's scope of practice, the nurse role in accreditation, chronic disease management. We've got some information about infection prevention and control, some further information there on cold chain management, and there's also some information on education opportunities with links to some education organisations. If you'd like a copy of the resource guide or to have a nurse orientation, you can please contact the practice support team to book this in. So I'd just like to thank everyone for attending tonight, and thank you very much to our speakers who both gave great presentations. I'd actually like to say a big thank you to you both, because I know that you were both unwell today, and I really appreciate your support for the nurses out there in primary healthcare. Yeah. So, and also just a reminder to please complete the online survey that will pop up in your web browser, and also our practice support, immunisation and digital health teams are here to support you with all things general practice, and that includes accreditation and nursing in general practice. So please don't hesitate to contact us here at CESPHN if you'd like any additional support. And just another reminder is that we have our cultural awareness training on Wednesday, the 1st of June at Canada Bay Club in 5 Dock. So please register via our events registration page. For general practices, remember that this is really important. If your practice participates in the Indigenous Health Incentive PIP, you must have a minimum of 2 staff members that have completed cultural awareness training, and one of those staff members must be a GP. If you'd like any further information on this, please contact the practice support team and we'll be able to assist you. Thank you everybody for attending tonight and for our guest speakers, and we look forward to seeing you online soon. Have a good night. Thank you.